Hey everyone, good afternoon and welcome. So you're all here and can hear me, see me. Hey, cassette. Boy, I wonder if there's gonna be a drop off here in viewership since I know you guys have a couple of days off coming. Shelby. So Kelly and Isabel. 3 days just to study. It's pretty good. Okay. We're gonna start here in just a few minutes. I'll see if anyone has a question. Of course, I always put them up on the sticky board or wherever. Actually, end up a little early. Today is only 12. So, that is interesting. I might use that extra time to get ahead since we are still behind. We'll see how that goes. But I'll still leave the lecture material for the test the same, so it'll be covering endo, nephrology, and surgery. So I'll still keep the exam about around. How many units will be on exam 4? Looks like it might be about 5. So the Jerry section is relatively short, and the immunization section is relatively short. So it's almost going to be like the material of about 4 sections, even though it'll technically be 5. Like geriatrics is tough because it's kind of like we talk about geriatrics like in everything because we, you know, treat a lot of old people. Good day, mate. Don't worry, no accents today. We're keeping on very serious and on track. All right, well, it is 12:30. People I got in the room here. 14. That's all right. I know people are probably excited to go and have their few days off. Maybe they're traveling somewhere. Who can say? Maybe going to the beach to study. I have no idea. That's okay. This is recorded in perpetuity, so you can always come back and watch later if they need to. So, Aaron. So anyway, so as I was saying, I'm not sure how much I'm going to get through today, and in fact, I might use the next block whenever we meet to actually get ahead a little bit for the next test. But the exam material is still going to stay the same of endo, nephro, urology, and these surgery meds. So that's going to be test 3, and then as I was telling you guys earlier, test 5 might have test 4. You don't have 5 tests. I don't want to scare anyone. Test 4 might have like 5 sections on it, but some of them are a little bit shorter, kind of quick hits. So It'll be roughly the same amount of material, so I don't want anyone to worry about that. But here we are recording. We were discussing sort of the process, or sort of the physiologic changes that occur when someone undergoes anesthesia. And again, anesthesia is kind of a wide range of things we can be talking about here, and it's something I do quite like. I think it's really interesting and kind of neat how the drugs are all working together and sort of the different physiologic effects they have. But recall, you can go anywhere from like a very light sort of sedation, maybe a little bit of amnestic sort of properties, down through total, medullary depression, which is obviously not how far down we want to get in a lot of cases. But we're going to see things and think about things like respiratory depression, and what do we need to do to make sure that respiratory or the respiratory tract is intact, and making sure that we can breathe for them if we need to, or be able to administer medications through our airway if we need to. Different things like that we'll be kind of talking about as we get into specific drugs. So here are the inhaled anesthetics. These are going to be drugs which obviously they're inhaled. So they're going to be taken into the respiratory tract. This can be done either with something as simple as like a face mask. They can be administered all the way through the endotracheal tube, depending on sort of what drug we're talking about and how they're being used. You're going to find that these are not going to be great for like quick sedation, like to quickly knock down a patient in terms of consciousness. These are good for like maintenance of sedation, as we're going to see here in a little bit. But basically, these gases or vapors that are being sent down to the respiratory tract. And we're going to find that a lot of different properties are going to have, or different, sort of variables are going to be influencing how well these drugs are going to work. We'll talk about things like the actual partial pressure of the gas, which is sort of like our dose. So what kind of kind of concentration of total air is being taken up by these inhaled anesthetics. Obviously, you don't want it to be 100%, because then your patient's not getting any oxygen. And then we're going to find that it has to be able to partition from the air that's in the lungs through into the bloodstream. And then from there, it needs to be able to partition into the brain, right? So that way it can actually work to cause the sedation that we're going for. And we'll see that different drugs may have different abilities to do that, which may affect like the overall potency of the drug, overall, like how good of a sedation we can get out of it, And again, depending on the type of surgery you're dealing with, whether it's like a wisdom tooth removal, which may not require a whole lot of sedation, versus open heart surgery, there's different drugs that can be providing, varying amounts of utility depending on the situation there, as we're going to see. So anyway, and remember we talked about the mean alveolar concentration of the MAC as a means of trying to compare different anesthetics together. And that's going to come up as we look at a few of these in comparison to one another. Anyway, so we're going to see again that a lot of what is going to influence how quickly these drugs kick on in terms of efficacy include the solubility properties, concentration in the inspired air, which is that kind of partial pressure I mentioned there, the volume of pulmonary ventilation, so the more area of the lung you can take up, the deeper inspiration, the more absorption you may get there, pulmonary blood flow, and then you're going to see here again that partial pressure gradient differential between the arterial and the anesthetic concentration. So sort of the difference in between the concentration in the blood and what's in the air that's in the alveoli. And obviously the greater the difference, the greater the transfer of gas is going to be seen there. So if you were to look at just an idea in terms of like different anesthetic solubilities, you can see here that if you're looking at the arterial anesthetic tension, or the percent of inspired tension, so basically like the air that's coming in terms of, what percentage is then being transferred over into the bloodstream, you can see here that some things just aren't very soluble, and so they're not going to be able to cross over very easily, versus other things may have a much easier time. So something like nitrous oxide, which we'll talk about more so in just a little bit. So again, these are just kind of comparisons in terms of solubility. Not every drug is going to be built exactly the same there. But once they get into the brain, what are they doing? What's their mechanism here? And basically, they're mostly working on GABA A receptor channels, just like something like a benzodiazepine would, just like a barbiturate would. You're going to find that these are the primary targets. By activating these channels, you're going to have influx of chloride that will hyperpolarize the neurons, and thus they have a harder time firing there, right? And again, you're going to find these typically are going to be pretty sensitive to our inhaled anesthetics, we're going to see here. And then again, by using a combo of something like an inhaled anesthetic plus an IV anesthetic, you can get a lot of good synergy there. So if I'm using like an IV benzodiazepine like midazolam plus an inhaled anesthetic like on sevoflurane, which we'll talk about the specific ones in a little bit, you get much better and deeper sedation than you would see by either one by themselves there. A lot of synergy here. So the ones we're going to talk about as part of what we call balanced anesthesia, between balancing the effects of IV versus inhaled drugs. Here are the main ones we're going to run into. Nitrous oxide, which is a pretty common one you're going to see in a lot more procedural sort of settings. Halothane, enflurane, isoflurane, sevoflurane, and then desflurane. I will always remember sevoflurane because I remember that was my dad's internet password when we first got the internet back in the day, and we had to pay by the minute. That was his password because he was a CRNA. So it's not, he has much stronger passwords nowadays, but for whatever reason, sevoflurane always sticks out in my brain. So I knew how to spell sevoflurane as a kid because once I figured that out, I was like, ooh, I can get on the internet now. I can go into the message boards and post stupid stuff. Anyway, so as I mentioned, the mean alveolar concentration is what is basically telling us what concentration of the drug is needed to cause immobility and depress consciousness in 50% of the patients, right? Which basically is like your patient's not responding to noxious stimuli. So I can cut into the patient and they should not respond. How amount of drug would it take to cause that in 50% of the patients? Now, again, we're going to find that we don't want to dose it to where only 50% of our patients are actually anesthetized. Like we'd probably prefer closer to like 100%. So typically you may be using something like 1.3 times the MAC, and that gets it in about 95%. So even a little bit above that, you're probably shooting close to 100. And again, remember you have IV drugs that are also helping out with this as well. Things that may affect how well a patient responds to this is kind of interesting because, you would normally think like, okay, well, the size of the patient matters because maybe you need more drug in order to affect the size. That actually doesn't have anything to play with it. So like sex, height, weight have no effect on the MAC for a particular type of patient. However, things like being elderly or being hypothermia, having a lower temperature, decreases your MAC. So it takes less drug in order to cause this, unresponsiveness to noxious stimuli. On the other hand, though, things like pregnancy, and what kind of makes a sense is things like alcohol abuse and chronic use of centrally acting drugs, meaning like depressants. So if you're chronically using opioids or alcohol or benzos, your brain's sort of used to having that depressant effect around. Is going to take even more anesthetic in order to cause your patient to become sedate. So that can make a difference there in terms of like, you have a patient who you're expecting to respond a certain way given a certain dose. You then have to go above that because maybe they did not disclose that they have they chronically abuse alcohol or something like that. So it's kind of interesting the varying effects there. It can make a drug more or less effective. And so looking at this, you can see that based off of sort of how you're shooting for that MAC, maybe a certain percentage of it, you can go anywhere from amnesia up to unconsciousness, all the way up to complete immobility here as you see more and more depressant effects. So given the type of procedure we're doing, we may not need that high of a MAC. We may not be needing to shoot for that high. If I'm removing someone's wisdom tooth, I probably don't need to have complete immobility. As long as the patient's kind of asleep and not really jerking their head around as you're trying to yank out their tooth, is probably going to be fine. So again, the dose is important here in terms of like what you're looking for a particular type of sedation. And again, we didn't do a lot of dental procedures, obviously, in the ER, but like for peds ER stuff, you do a lot of procedural sedation for things like dislocated joints or displaced fractures that you need to reduce. And in those cases there, you just need like the muscles to relax, because normally if you have a broken femur, your muscles are pretty tight around that because it's so painful. By giving an anesthetic, you're able to try to relax that, and then you can set it much more easily than if the patient was awake and conscious, right? We'll talk about more situational things as we go forward here. But other things we can see in terms of effects on the body systems of these drugs here, we're going to see cardiovascularly. Some of these drugs may cause hypotension, some may increase blood pressure, some may cause tachycardia, bradycardia. We're going to see that's a little more variable depending on the drug, as we'll see in a little bit. In terms of respiratory function, respiratory depression is the most common thing you're expecting to see here. So again, the bigger the dose you're giving, the more depressant effects on the respiratory drive. So again, that's where we need to think about protecting their airway, either using maybe a non-invasive or invasive ventilation for those patients there. You'll see in the brain, you're going to have decreased metabolic rate. You're going to see typically reduced blood flow to places like the kidneys and the liver as well. So overall metabolic activity sort of decreasing while using these. Now we'll get into the specific drugs here. Some of these are used a little bit more often than others. I will tell you the three that I see most frequently, at least in peds surgery. Certainly may see differences elsewhere. I'm sure most of you heard of like ether is being used in the past. It's a pretty volatile anesthetic drug that was used back in the day. Again, I always like drug movie references. So if you ever watch The Cider House Rules, Michael Caine was using a lot of ether. He would put it into a rag and basically huff it in order to go to sleep. What was interesting about ether is it is highly flammable, which is not great if you're trying to like cauterize something. So back in the day, especially with like electronics things plugged into the wall. So actually, if you ever look at like really old surgical suites, they used to have plugs that would actually be above a certain height on the wall. There's actually like a metal bar usually kind of delineating how high those plugs had to be, because if it was down below a certain level where the ether would settle out, you could cause fires to happen just by random sparks and things like that. So we don't really use it that much anymore. So, this is a good question. So someone says, does being a natural redhead increase the MAC? Maybe we have a return of the MAC, who knows? So that's actually something really interesting. So I had a student bring this up. I think it was last year. I think it was one of your upperclassmen might have brought this up, but it is something showing that natural redheads actually have a pharmacogenetic sort of, I think it was increased pain tolerance. Let me see. I remember. Redheads, pain, or the pain susceptibility. What is it? I'm sorry, they have an increase. Let's see, redheads are hard to sedate. They have a different tolerance for pain. I remember the specific. I haven't looked it up in a little bit, probably about a year or so. Yeah, so more tolerant to local anesthetics, but more resistant to opioids. And so, yeah, so that's really kind of interesting how here in this case here, you would see that it looks like they are actually more tolerant to the local anesthetics. They'd actually have an increased MAC. So they would actually have to require more drug in order to overcome that. But in other cases, you may find that they're going to require, they have different pain tolerances, and so they may actually require more drugs in some cases. So I think Dr. O had a recent acquaintance or somebody who was having a baby, and they actually said, hey, you need to like make sure you're actually dosing me appropriately with this epidural. And certainly enough, they had to like really kind of go up with a higher dose than usual. I don't know the specific mutation that causes that. I don't know. I'd have to do some more research there, but it's really interesting to see how like this hair color is like also associated with certain pharmacogenetic sort of occurrences of things like pain tolerance and things like that. But it's pretty wild stuff. Yeah, so you may require more drug in order to overcome that. And of course, I'm sure any seasoned anesthesiologist or CRNA would be able to certainly know about that for sure. But I need to do some more research on that. I always find that interesting. They say redheads have more fun. Maybe not. Maybe it's because they feel more pain. Who can say? Anyway, so getting back into it. So halothane is going to be the first drug that we're talking about here. Again, it's working on those GABA A receptors to allow more chloride influx, thus to hyperpolarize those neurons there. So really strong inhibitory factor. We'll talk about like the onset and recovery phases here. And this is important because of how we're using these drugs. And I'll show you the few that I see used much more frequently with our anesthesiologists nowadays. And a lot of it has to do with the onset and recovery. So one thing you're going to find is that recovery is probably more important here than onset, but basically that means is like how quickly would it kick in order to cause anesthesia in the patient. Well, most of the time we're using IV induction agent, so we'll use something IV like a benzo or an opioid or something to try to induce anesthesia in that particular patient. Use IV first because that's more fast acting, but then you kind of switch over and you're kind of using a balance maybe between the IVs and the inhaled anesthetics. But you want that patient to be able to recover quickly once the surgery is done. You don't want to like finally close up the patient. All of a sudden it takes them 3 hours to start breathing on their own again. A fast recovery when they go into the post-anesthesia care unit, which is the PACU, which is typically where most people end up after surgery before going off into either the floor, they go home, or the case may be there. So you want something with fast recovery. So we're going to see here the halothane is probably not really going to fit the bill from that standpoint, but this is a little bit of an older drug that's been used for quite a while. You'll also see that it may not be great in terms of analgesic potency, which is not awesome if you're trying to like cut into somebody. So you may need it with like another anesthetic agent. So you may see this used in conjunction with something like muscle relaxants, or you may see like thiopental, which is a type of barbiturate we'll talk about in a little bit. And then you'll see that in terms of its ability to be eliminated, it usually just gets expelled. So it'll partition back out across the blood into the expired air. and can just be eliminated that way. Again, it kind of has a pleasant odor to it, so maybe that can help out if you're doing a more minor procedure and the patient's having it on their face or something. Enflurine's another one that's a little bit less potent, so you need more of the drug in the inspired air in order to get the same sort of effects here. And has, again, another medium sort of onset and recovery. However, this may have a little bit more rapid onset than something like halothane, and it has faster awakening. So that, again, that's a good thing. You want your patient to recover quickly when you're done. The other big thing here too is it's a nice skeletal muscle relaxant. Now that's important for surgery because you don't want your muscles all tightened up, especially like in the abdomen if you're doing abdominal surgery. If you're doing ortho surgery, you don't want the muscles around a joint or the bone to be really tight. That's going to make things more difficult for you. So not having those natural muscle relaxant effects are good. But again, looking at the side effects here, we're going to see things like respiratory depression can happen here. You will see some risk for arrhythmias. In this case here, it's a little bit lower than halothane, but basically, these are hydrocarbons. I mean, in terms of like chemicals, these are considered to be hydrocarbons. And one of the things you'll find is they can actually sensitize the heart a little bit to catecholamines like epinephrine and norepi. And so it can run the risk of having a tachyarrhythmia. And that's actually something really interesting you'll see with patients who are huffing off like Freon off of like an AC unit or something like that. You'll actually find those patients that do that, which are typically adolescents or sometimes adults, but you can see that as a form of getting high. They can actually die from ventricular arrhythmias as a result of that. And so these kind of all fit into the same sort of hydrocarbon sort of category there, which is kind of interesting. Other things you're going to see, hypotension, you may see seizures very rarely, but that can potentially happen there. Now, normally if your patient is like super sedate and anesthetized, you may not see them actually have convulsion, so it may be something where an EEG may be necessary to see if they're in sort of a non-convulsive sort of seizure sort of thing there. And if they have hepatic and renal dysfunction, you can find that it can slow down the metabolism and excretion, and then you may have some longer duration of action there. So that would be one downside. Isoflurane. Now, the three that I see used most often, to be honest, in terms of like general surgery, is typically like ISO, SIVO, and what's the other one I'm trying to think of? Desflurane. So this is starting kind of the three that I see used most frequently. So ISO, Des, and sevoflurane. I've never really seen a lot of halothane or ethane being used or enflurane being used before, but these three I certainly see quite a bit. And our anesthesiologists typically prefer that, so that's kind of why we carry that. It's because they've trained with it and they like it. So the reason why we like things like isoflurane better than halothane or enflurane is because it typically has a much more rapid induction, and you find a lot faster awakening. Okay, so that's one benefit to something like this is that they wake up faster, they can recover faster, and you get them out of the PACU, and you get your next patient in. Right. So again, throughput is very important from a surgical standpoint because if you can get more people through, you can recoup more money, and thus you're making you're a good business at that point. Not that money's the main goal here, but you will have certain metrics that you're supposed to be meeting in terms of surgical throughput to see all the patients that you need to see. But you're going to see here, the nice thing with isoflurane, also you see less post-anesthetic organ toxicity, so not a lot of liver or renal effects, no seizures for the most part, and it also doesn't induce arrhythmia. So this is why you start to see this newer generation, starting with isoflurane, being used more frequently because it's a much more favorable side effect profile than something like halothane. Other things you'll see with this is you're going to see that it does reduce or cause respiratory depression. So again, most of the time your patients are in a situation where they're going to be breathed for anyway with a ventilator, so that's less of a risk there. Can see some hypotension, and you may see some increased cardiac output, probably due to a decrease in the afterload as a result of you decreasing your blood pressure. Desflurane, you may see in some cases of things like emergent sort of surgical settings. You may see in outpatient surgeries for more minor procedures like dental things and things like that. And then in terms of its use here, very rapid recovery, about 5 minutes or so, which is why it's good for like outpatient surgery where the patient's going to be recovering and then going straight home, as opposed to something like, halothane or something where some patient may be sticking around for longer. The other nice thing, or the downside here, though, is it's a very poor inducer. So that means you would definitely need to have something IV in order to knock the patient down first. And then this would keep them sedate until they can then be discharged home for their, if they're having a more minor procedure being done in those situations there. Here you're going to see some respiratory depression. You may see myocardial depression. Other things you might actually find associated with this as well includes things like cerebral and coronary artery dilation. clinically if this really caused a lot of problems, not a ton that I'm aware of. But the other kind of dangerous thing you can run into would be something like laryngospasm, which is really sort of emergent sort of situation where maybe you try to extubate that patient, but all of a sudden the larynx starts to tighten up and become spastic. So it's not, and basically the patient cannot breathe at that point. That can be a really big deal. So a lot of times we, at least I know at our hospital, we have a kit called the laryngospasm kit that actually includes a couple of sedative agents, which we'll talk about later, along with a paralytic. The paralytic is going to help to basically paralyze the larynx and allow for the patient to be able to breathe again, along with some ventilatory support there. So that's a clinically really important thing for patients who are recovering after being extubated when it's receiving some general anesthetics. Sevoflurane, this one is, again, rapid onset, rapid recovery, which is great. In terms of side effects here, nausea, vomiting tends to be a little bit more common with this one. This is something you want to consider too. If your patient is now waking up and they vomit, they may not be protecting their airway super well, and that can cause things like aspiration. So that's one thing you'd want to be really cautious with from that standpoint. Most of the time, these patients are getting some antiemetics anyway. So very frequently, and again, I deal with surgical patients all day long. I was doing this yesterday when I was at the hospital. We do all the pre-op and post-op orders. And so you'll typically see that like during surgery, they'll get like a dose of Zofran. And then usually when they're in the PACU recovering, they'll have an as needed dose of Zofran available as well. So that way if they start to, or the nurse, that's taking care of them, notices they start to get nauseous, just go ahead and give them a dose of Zofran and try to prevent that. Because if they're still kind of sedate and they end up aspirating, that causes all kinds of problems you don't want to deal with, right? Here you can see some hypotension, and this can either cause a risk for brady or tachyarrhythmia. So again, you just have to be watchful and kind of see how the patient's responding. And there's different ways you can manage those, whether it be with a beta blocker or something to stimulate heart rate. But most of the time, you can just kind of watch it, and it's generally fine. So next we have nitrous oxide. N2O, again, this is not the same as nitric oxide. Sometimes we do use inhaled nitric oxide for patients with really severe pulmonary failure. That actually helps to dilate some of the pulmonary vessels in the lungs there, but this is nitrous oxide. Again, a big difference. I don't know if anyone's ever seen the movie Black Sheep with the late and great Chris Farley and David Spade. They actually stole a cop car at one point that had a nitrous system in it, and it started leaking, and so of course it leaked into the car, and it was a very funny scene. If you've never, you can Google it if you want to, but they call it laughing gas because typically patients get sort of almost like kind of inebriated when they're using this, and things seem pretty funny. Just to share a personal story, one time when I was getting some teeth removed as a child, I had some teeth that were kind of stuck in for whatever reason, and so they decided to come in and take them out. I got some nitrous oxide beforehand, so I had this mask over my nose that I was breathing in, and the provider came in and they were wondering if I was ready to go or not, and so they said, okay, well, let me tell you a story to see if the gas is working for you. Keep in mind, probably like 11, 12, probably around this time. And he goes, okay, so a panda walks into a restaurant, sits down, orders a meal. Eventually the meal waiter comes up and provides him the bill. The panda takes out a gun, shoots the waiter dead, and then runs out of the restaurant. And someone at the bar says, oh my goodness, why in the world did the panda do that? The bartender says, we should look up panda in the dictionary. So the guy did. It says pandas, eats, shoots, leaves. I thought that was hilarious. I died laughing, and the provider said, I think you're ready. So, and then they went ahead and took my teeth out. They grew back though, so don't worry about my teeth. Anyway, so again, that's all laughing gas. So hopefully that kind of gives you some idea of what it's like. You can make me really laugh at puns, which is probably no different than baseline. But here you're going to see nitrous oxide is really not able to induce as deep of an anesthesia as any of the other drugs we've looked at. So this is really relegated more towards those more procedural sort of sedations. Light sedations, if you need to do like a minor procedure, think like if you're doing like an incision drainage in the ER. Imagine if you're doing perhaps like, again, a lot of dental procedures, you could do this. I'm sure there's a million I can't even think of. We're not really set up at our hospital to do this, but you will see some places where they can have like a procedural anesthesia unit where you can send people over to get really light procedures done. And that actually is a pretty good service if they can get that all set up. But anyway, and you can also use it as a supplement. So for instance, I think during one of those procedures where I got nitrous, I also got like some propofol to go along with that for the actual procedure itself. So it just depends on the situation, which I'll talk about propofol in a little bit. Again, not effective as a single agent, and again, you're typically just be able to breathe it back out in your expired air there. In terms of side effects, things you want to watch out for include things like hypotension. You're also going to see a lot of nausea, vomiting associated with this. So something like Zofran is certainly going to be recommended in addition to that. The other thing to look at too is it can actually cause expansion of gas in air cavities. This is something you don't really think about too often, but is pretty interesting, is the fact that the gas itself may be able to expand in certain air cavities, and so that may lead to things like distension of the bowel. You can see, again, the gas can partition into different compartments and cause expansion there. So things like pneumothorax have happened. People have had ruptures of their tympanic membranes because the pressure in there built up so much that it popped. So again, not common, but something you'd want to at least be considering when dealing with the patient there, to be like, wow, maybe this patient has a lot of maybe chronic otitis and they haven't got their tubes placed yet. Maybe this is something that could be a concern. Just something to think about. In terms of contraindications, I don't want to give this to pregnant women. It is known to be teratogenic. And you can also cause some issues like in immunocompromised patients or patients with anemia. It actually impairs, I think, the activity of, I believe, folic acid is one of the B vitamins that gets affected by this, or B12. I think B12 actually can be affected, which is why it can cause things like anemia. So that would be one thing you want to be careful of. And again, this is more of a chronic thing. If you're like kind of chronically getting exposure to nitrous oxide, which is, you wouldn't think to be common to most people because it's kind of a very specialized sort of thing. You'd have to like go to a place in order to get. But again, if you think about things like, certain healthcare providers may be abusing substances in their workplace, this is not an uncommon one to see. Things like, dentists or, anesthesia providers may be abusing nitrous oxide, for their kind of the fun, happy feelings you get from it. But anyway, looking at this, you can kind of get a good comparison between the nitrous oxide and the other general anesthetics that we talked about here. Again, this is good for just kind of comparison purposes if you're kind of trying to compare and contrast. But also look at the MAC between these if you can kind of guess to see like which ones would be good for causing sort of complete anesthesia versus ones that may be really poor at that. So for instance, in order to get the minimum alveolar concentration to get a patient, 50% of patients to not respond to a noxious stimuli, it'd be over 100. So that means you're having to breathe in more. You'd have no air at that point. You'd have no oxygen to be breathing in at that point there. So again, this would never be used as a general anesthetic, whereas the other ones be much easier for them to be able to do that. Much more potent in terms of their effects there. So little things to kind of compare and contrast. In terms of looking at the general cardiovascular effects you're expecting to see here, these are just some general comparisons. I don't know that I'm going to ask you specifically, does halothane cause decrease in MAP? I mean, yeah, most of them cause a decrease in mean arterial pressure. Not a lot of them are going to cause hypertension here. But again, this is just for general consideration. Might I ask you, which class of drugs is known to cause tachyarrhythmias? I might, compare a general anesthetic versus a barbiturate versus a benzo or something. In that case there, I'd want you to know which one's the general anesthetic, and yeah, that can cause tachyarrhythmia, things like that. But I don't know if I'm going to get real specific and nitpicky between the individual cardiovascular effects between like desflurane and sevoflurane, right? I'm going to be focusing more so like on the utilities of the drugs, how you're specifically using them. Maybe if there's like individual side effects, something like, anemia or seen with nitrous oxide, that's interesting. That's something unique to that. Little things like that you may want to kind of hone in on. Now, in terms of organ toxicity, you can see some hepatonephrotoxicity upon recovery. So again, it's something you want to watch for over the course of several days after they receive the drug. And there's something called malignant hyperthermia, which is particularly nasty and not super common that you can see. But basically, this is something it's a genetic condition that can be unmasked by the exposure of a patient to these general anesthetics. And basically, it's an autosomal dominant genetic disorder, and it's something that is rare, but for many people, they may never even know that they have it, right? So this is basically a mutation in the ryanodine receptor. If you're not familiar with that, that is one of the receptors that's responsible for causing calcium to come out of the sarcoplasmic reticulum when you need your skeletal muscle to contract, right? Remember the idea of calcium-induced calcium release that occurs within skeletal muscle. You have a little bit of calcium coming in. If you have an action potential that says to contract the muscle, that then causes the sarcoplasmic reticulum to release a whole bunch more calcium that causes the actin-myosin to come together, and then your muscles contract, right? Well, these patients have a susceptibility issue to where they're going to have way too much of an exaggerated effect due to the exposure of these local anesthetics. Nitrous is not really known to cause this as far as I know, but it's more so the general inhaled anesthetics like isoflurane, sevoflurane, things like that. And so, for the most part, we don't do a lot of like routine genetic testing to see if people have this mutation. But in some cases, you may do, if you have like a history of like, oh, my family member had a really bad reaction to surgery to the anesthetics and they died or something like that. Like, that could be a sign that you want to do some further investigations there. So you can sometimes do like a skeletal muscle biopsy, and that's actually the most reliable test where they can actually give you, show some, give it like exposure to halothane and see if it has this contraction issue that pops up there. So again, not commonly tested for necessarily because it is pretty rare that it occurs. But it's one of those things you need to recognize like immediately, otherwise the patient might die. So what's happening here is, again, you see the calcium coming in through the channel, and then that causes the ryanodine receptor to open up and allow calcium to flow through. In the exposure to some of these inhaled anesthetics, and there's actually one paralytic we'll talk about as well that can do this, you will then cause a ton of calcium to be released, which causes a lot of metabolism to occur. You're going to burn through a lot of your intracellular energy, so which is going to lead to a switch from aerobic to anaerobic metabolism. Thus, you're going to get a lot of heat, you're going to get a lot of acids being produced, and because there's so much calcium affecting these myofilaments, they cannot relax, and so you get a lot of rigidity, which I already said was not great for surgery in the first place. That's why we like the muscle relaxant effects of those anesthetics. So what happens is you may have a patient who's getting undergoing surgery. Everything looks like it's going good. You're about to maybe cut into the patient, or maybe the patient's already opened up, whatever the case may be. All of a sudden, they get tachycardic and hypertensive, and their muscles start to tighten up. Very, very tight muscles, almost similar to what we saw with neuroleptic malignant syndrome. They can have that kind of lead pipe type of rigidity there. Because of that, they're going to hyperthermic. As muscles start to break down, they can become hyperkalemic, and they can develop severe acidosis. Okay, so the treatment of this is actually pretty similar to NMS. So you see dantrolene can be used here as a peripheral muscle relaxant, and it actually helps to reduce that calcium release from the sarcoplasmic reticulum. So in both cases, whether it's NMS or malignant hyperthermia, you can still use dantrolene for either of those cases there. And again, even though the mechanism is quite different, different due to the drug exposure and whatnot, that's you can still use the same drug there. And again, the two places you're going to find the malignant hyperthermia cart in most hospitals will be in the ER, where they might use one drug that can cause this, and in surgery. So in the OR, you'll find a cart available that has cooled IV fluids. They'll typically have a ton of bicarb in there, sodium bicarb, to try to, neutralize the acid. And you'll find this dantrolene here in order to help kind of deal with that muscle contraction there. And so by giving bicarb, you can try to suck potassium back into the cell. You can deal with the acidosis, and hopefully you can reduce that temperature down. And again, if you don't catch this early, the patient can certainly die from that. So really the biggest thing that's going to happen with the inhaled anesthetics, and there's a drug called succinylcholine, which is a paralytic, which we'll talk about at a later date. I'm not sure if it's in this section or if it's in the ER section, but we'll talk about succinylcholine a little bit later on. So anyway, so again, the key points of the inhaled anesthetics is, again, they have good amnestic effects. So even if the patient was somewhat conscious of what was going on, they'll forget a lot of the details there, sort of a brownout, blackout sort of effect. They will typically, we're looking for things with quick offset, so that way the patients can recover faster. And this is a good add-on or an adjunct as sort of agent to IV anesthetics, which we're going to talk at length about here in the next section. And it's important to be able to provide that balanced anesthesia. So you need the IV to induce, and then you need the inhaled stuff in order to keep them sort of sedate throughout the period. Again, IV or inhaled. As I mentioned, sort of the onset and offset is going to be affected by their solubility. Some of the later ones we talked about, like sevoflurane, have very fast offset, so that way the patient can recover that much faster. And in terms of monitoring, look for malignant hyperthermia. You'll see that in the vital signs. You'll see that in the expired CO2. If you're monitoring for that, you're going to see that in the temperature of the patient, which you're all monitoring usually during surgery anyway. And then for post-op nausea vomiting, Zofran's the way to go for the most part. I have some anesthesia providers that like metoclopramide, like Reglan for whatever reason. Either of those are going to be totally fine. Okay. So certainly what I deal with more, so from like an ER sort of setting or like a ICU sort of setting here, are going to be the intravenous anesthetics. Again, you don't see a ton of pharmacists working in surgery specifically, but you'll still run into them on some occasion, like in larger adult facilities typically, but I'm still used to more the ICU ER sort of setting here, and we use a lot more intravenous anesthetics for the most part. So here we're going to see that they mainly are used either as monotherapy, so you could use this for like shorter procedures by themselves. You could use this for induction of general anesthesia, and again, they can provide useful as an adjunct to the inhaled. So you may see a case where they will have one of these IV anesthetics used as a sort of inductor, and then you keep them on that throughout the duration of the surgery in order to help out the inhaled anesthetics kind of work even better. So someone was saying, so the calcium-induced calcium release due to the anesthetic. So no, that's how your muscles normally work, is you have calcium coming into the skeletal muscle, and that triggers the sarcoplasmic reticulum to release more calcium to cause the actual contraction to occur, right? That's a normal process. For whatever reason, these patients have a ryanodine receptor mutation that causes that to be much more sensitive in the presence of the inhaled anesthetics. And so they're going to get a much more exaggerated response, which is why you get that really tight muscles, you get the acidosis, the heat, all of that, because the muscles are basically in overdrive, essentially, causing them to, I mean, you can have rhabdo that can develop from this. I mean, it can be very severe and potentially fatal. Again, in the middle of surgery, which is not the ideal time to all of a sudden have an emergency, for sure. So that's why we like to screen for that stuff. So family history is really important. Ask about any history of like bad reactions to surgery or anesthetics, either themselves or their family members, because again, it's autosomal dominant. So even having one copy of it is going to be enough for them to potentially run into some issues. So anyway, and again, a lot of people may have that mutation, not even know it because they never get exposed to some of these anesthetics. You know, some people can go their whole lives and never know about it, right? So again, we're going to find that the IV anesthetics typically have a much faster onset of action than your inhaled anesthetics, which is why they're good for induction. Most of them do lack some analgesic properties, so I'll make note of that where they are. So typically you may need some add-on drugs to help out with the analgesia standpoint, right? Depending on the type of procedure that you're doing, for sure. And again, we like to have quick recovery times, but often this can be dose dependent. So frequently we try to give as little as we need to cause the patient to be comfortable, and not be squirming around on us and things like that, but also they can recover fast. Not so much that it takes them hours and hours and hours to recover, because especially like in the ER setting, like you need to get that patient moving on out and on to wherever they're going to be going, because you got to see more patients, right? Not say you don't like your patients, but just say throughput is a very important consideration in the surgical realm, in the ER realm, all of that. So talking about here, we're going to get into our sedative drugs. This is like some of my favorite sets of drugs. I always find these really interesting. Barbiturates, our benzodiazepines, our opioids, propofol, etomidate, and then ketamine, which is one of my favorite drugs out there. I always find it super interesting. Sometimes I teach I help to adjunct and facilitate a class for the College of Pharmacy, UF College of Pharmacy, because I help out with some of their stuff on occasion. And I like to ask for their class. I like to say, okay, so tell me why you want to take this class and tell me what your favorite drug is. And most of the time, I don't know if you guys have met any pharmacy students, but they're kind of like me. So they're kind of like a little type A, buttoned up, a little more maybe on the conservative side, kind of nerds, if you will. But anyway, so I remember, a lot of their answers being like, oh, I like Tylenol. Tylenol is my favorite drug because it helps when I have a headache. And I was like, well, that's not really interesting. But then finally I got to the best answer, and someone said birth control. It was the guy. And I said, oh. Of course, the whole class was laughing, but I always thought it was one of the best answers I heard to that drug. What's your favorite drug question ever? But some people like things like ketamine, or so always an interesting answer. These are some of my favorite sets of drugs, but not for personal use, for clinical use, because they're so interesting. Anyway, so getting into sad I have a fewer people watching this time than usual, but maybe they'll be able to follow up on some of the jokes here, and they're watching it later. But regardless, getting into it, so the barbiturates, we talked about them briefly in terms of their use for surgery. And again, you can find certainly multiple uses for these drugs through the same mechanism, right? So I can sedate someone so that way they can be intubated. I can treat their seizure. Sometimes you're doing both at the same time. So again, it's good to know kind of the different uses for these drugs here and kind of what we're going to be using them for in terms of the clinical context and all that. But anyway, with barbiturates, the three main ones you're going to find here include things like thiopental, phenobarbital, and pentobarbital. From a peds perspective, if that's what you're interested in, phenobarb is probably used most often in the NICU. I don't really use a ton of other barbiturates, but if you're working like in a trauma center, adult ER, you're certainly going to see a lot more of this, depending on sort of the situation there. But again, works through the GABA, right? GABA A is still the main thing we're seeing here, helping to depress activity, decrease excitable tissues in the CNS, and overall you're going to see depression of the CNS, you're going to see depression in the respiratory drive and all of that. And interestingly enough, if a patient was actually getting electroconvulsive therapy, which I already know I've used the shocking joke before, so I won't drudge that up again. But this is actually the drug of choice for that. So and again, this is because the barbiturates are old drugs. They've been around for forever. And so they've been used to help kind of facilitate electroconvulsive therapy, which is probably not something you want to be super conscious of when having that done. Oh my goodness, someone said, sorry, but the best Wi-Fi password would be methylene dioxymethamphetamine. That's until you have to like tell someone that's coming over to your house actually what the Wi-Fi password is. And I'm sorry if I misconstrued my story there. This wasn't the Wi-Fi password I was talking about. This is the internet password to actually log in through your ISP, because you had to pay via the minute, and this is through a phone connection. So I know a lot of you are too young to remember this. But yeah, it was not Wi-Fi. This was many years off since then. So yeah, thank you for making me feel old. That wasn't the intent, but it certainly feels that way. Just kidding. Anyway, I think my Wi-Fi name is Get Your Kids Off My Land. But I will not give you the password. That is sacred info. Unless you come over to my house and you need it. But anyway, don't come over to my house. Anyway, so looking at this, we're going to see that barbiturates are good as induction agents. So again, they're really good to help kind of knock the patient down in terms of consciousness. You're going to find, yeah, this is way before Wi-Fi was invented for sure. Barbiturates, though, are not really good from an analgesic standpoint. So if they have something painful going on, you're going to need something in addition to that in order to get the analgesic properties. So typically opioids will be one of the more common things you're going to see there. I know that 56K modem sound is forever ingrained in my mind. Or like you'd pick up the phone and then you interrupt whoever is on the internet. That was always really fun to like kind of troll your siblings. They're on the internet doing something. You pick up the phone and it would totally interrupt it because we only had one phone line. But anyway, the early days of the internet were pretty wild. So we're going to see here also with the barbiturates, they have depressant effects on the cardiovascular system. So you're going to see drops in blood pressure, cardiac output. So again, you can see hypotension pretty commonly, and it'll actually drop your ICP as well, right? So it's not, I mean, I don't know if the Insane Clown Posse uses barbiturates, perhaps that is their deal, but it can drop your intracranial pressure. And that's actually really good for patients who have like significant like, head trauma, they're developing cerebral edema or something like that. This, by dropping their ICP, can actually help to prevent some of that, maybe even the herniation from happening. And so we'll use this occasionally. I've seen even like severe cases like DKA that was corrected too rapidly where the kid developed cerebral edema being treated with barbiturates as a sedative. So again, different uses for it based on its physiologic properties. Thiopental, again, this is pretty commonly used as an induction agent. If you're going to use a barbiturate, it's good in fast acting because it's pretty lipophilic and can cross the blood-brain barrier pretty easily there. And you'll see this rapid loss of consciousness. And again, if you're ever curious, if you're looking at the three types of drugs they use for lethal injection, actually one of them is probably going to be a barbiturate, if anything, because again, they do have good CNS and sedative properties there. And so anyway, so you're going to see decrease in blood pressure, stroke volume, cardiac output, as I mentioned before. And you're going to see as well, this is actually really good for a controlled, like a continuous drip. So again, when we were talking about things like, continuous infusions versus intermittent drugs here, you want things, if you're going to be keeping the patient sedate for a while, you can use things like a continuous infusion in order to keep them sedate, right? Just like we would see for, if you want to keep their blood pressure up, you'd use a continuous infusion of a drug in order to maintain that blood pressure. This is like in ICU sort of settings. In these cases here, you want something that's short acting, because that means that when you titrate it, it equilibrates quite rapidly to that. If you have something that's really long acting with a long half-life, it takes a while for it to get to that new steady state. So that's why we like short acting drugs for continuous infusions, because one, I can titrate it very easily. So if I need more sedation, I dial it up. If I need less sedation, I dial it down. And then when I'm done, I need to wake the patient up, I'll let the patient recover, then I can just turn it off and it clears more quickly than something with a long half-life, right? So, and again, you're going to see that by using these drugs together, and you will get some synergy. So for instance, if I had someone receiving nitrous oxide prior to getting the thiopental, I need less of a dose of the thiopental because I'm getting some synergistic CNS depression from that standpoint, right? And again, here you definitely want to watch for their respiratory drive, looking for things like end-tidal CO2. That's actually another important thing you might know somewhat about. I'm not sure if you cover this anywhere else, but not just looking at their respiratory rate. That can be kind of a bit of a false read on what their actual respiratory drive is like, because they can sometimes be bradypneic, and even though they're breathing at a normal rate, they may not be having sufficient depth of breathing. But by looking at their CO2, and if that starts to build up, that can be really indicative of them having pretty significant respiratory depression. So not everywhere monitors end-tidal CO2. That's becoming more common as time goes on. And again, as I mentioned, this is good for patients who have cerebral swelling because it does not increase ICP. If anything, it drops it, or it doesn't really do much to blood volume. So from that standpoint, pretty good. We like it for that. With our benzos, we're going to see this is oftentimes used as an adjunct because of its anxiolytic properties and also its amnestic properties, along with being a bit of a sedative. Here you will see some anterograde amnesia. So for instance, if I break my arm and I go into the ER and I'm really kind of anxious and nervous and all of that, if you were to give me a dose of benzo, I'd be able to remember everything preceding that for the most part. I'd be able to remember breaking my arm, driving to the ER, or whatever, but I wouldn't remember a whole lot afterwards, assuming I got a decent enough dose there. This is really handy for patients who, for instance, we see this a lot in kids where they come in, maybe they, I don't know, got hurt in like cheerleading practice, or they fell off a horse, or whatever the case may be, and they're in there and they're like super anxious because, you know, they don't know really what's going on. If they don't like needles and they have to get an IV placed, this is really helpful for the anxiolytic properties, and then they don't really remember a ton of the details there. Yeah, so Jackson's saying in-tidal CO2 is a gold standard for intubation monitoring on the trucks. Absolutely, because that's it again helps you determine like, okay, is the tube actually in the respiratory tract and not just down the esophagus? So that's one way you can do that. But yeah, in-tidal CO2 is a really good way to help monitor for how good your respirations actually are. So thank you for sharing that. And again, for every patient, I mean, like I think almost every single patient going back to our surgery at Nemours, they're probably going to get a dose of a benzo right beforehand, because again, it's a nerve-wracking sort of situation to go back for surgery. Then give this to them, they can chill out, and then they're good to go. So they're much more compliant patients at that point. You will find this tend to have a little bit slower onset, so that's why you may see intranasally used, you may see IV used for a little bit faster onset. Oral is typically going to be a little bit slower there. And rarely do we use this as monotherapy. There's no analgesic properties. You're not really going to cause that deep of a sedation if you're using kind of typical doses, but it's good as an add-on there. So the main ones you'll see most frequently with diazepam, lorazepam, and from a surgical standpoint, an ER standpoint, we use Versed or midazolam sort of most often, either intranasally, IV, PO. That's really our drug of choice there, because it tends to have a little bit shorter duration of action, also has a little bit faster onset. It tends to be more lipophilic than something like a lorazepam or diazepam, so it's able to get into the CNS a little bit faster and do its thing in terms of causing anxiolysis and all of that. So good sedative, good anxiolytic properties, causes a high incidence of amnesia, which is what we're looking for, right? I don't need to remember the patients having their bone set or having their abscess drained or whatever the case may be. And because of it's having a short elimination half-life, you get a little bit faster recovery. So again, good from that standpoint. And it's a pretty steep dose response curve, meaning even tiny increases in dose, you can definitely see some more exaggerated effects there. So again, if you notice one dose is not really cutting it, you can always give a little bit more. You should be able to see definitely a good synergistic, not synergistic, but you should see a good additive effect there in terms of the total cumulative dose they've gotten. Now, one thing I haven't mentioned before, I don't think, at least I think I have, is a drug called flumazenil. And so if you were to think back to your opioids, as Narcan is to opioids, flumazenil is to the benzos, right? So this is the reversal agent for that, and they antagonize the benzodiazepine receptor, right? Remember, benzos bind to the benzo receptor that help GABA to work better. This is going to block that and antagonize that. And so this actually can help out if you have patients who are sort of like excessively sedate after a dose of a benzo. You need them to recover a little bit faster. Or in some cases, if they're having like an overdose or something, you could use this to potentially reverse that effect. Now, I will tell you from an overdose standpoint, I don't hardly ever recommend this or use it, because for the most part, the worst thing that's going to happen to a lot of these patients with benzos is they're going to be asleep, or if they've already been intubated, then they stay intubated for a little bit longer. The problem you're going to run into is patients who have chronic benzo use. If you reverse this with flumazenil, guess what you can do? Well, if the brain is used to having all this benzo effect around, all this extra GABA effect, and all of a sudden you take that away, then glutamate, the balance goes from GABA to glutamate, and thus you're going to see more excitatory actions, you're going to see seizures, right? And how do you treat a seizure? Is it due to benzo withdrawal? Well, you got to give them more benzos, right? So it can cause even more sedation. So I don't recommend it a lot, but you'll still see it used sometimes for patients who are going back for surgery who are not chronically on benzos. Maybe they're just getting the dose for the first time ever in their life, right? That's perfectly fine. They're not really used to having that benzo effect around like you would see with someone who's been on for weeks or months or years potentially, okay? So you can use it. It has a short duration of action, which is probably fine for most benzos. You don't need to really last for that long, as opposed to like an overdose. You may have more kind of extended duration of action there. But for the most part, this is good because it helps out with a faster recovery, so that way they can go home or go to the floor or wherever they need to go to. What kind of question? They said. So we need a lot of midazolam for a patient during a reduction of his fracture. Is there a reason why some people would need way more than usual? Yes, perhaps they were a redhead. I don't know. Some of it has to do with one, like, and again, if you're just giving them Versed for a fracture reduction, that sounds unusual for my practice, at least with peds, mainly because that's a very painful sort of thing, and Versed is not going to give you any pain relief. It doesn't cause any analgesia. So from that standpoint, I would say, adding on something with analgesic properties may have helped with that, right? And that would cut down on the edge, and you can use less of the Versed from that standpoint. When you're doing things like joint reductions or fracture reductions, things like Versed or benzos are good because they act as a muscle relaxant, so they do help out from that standpoint, but they don't do anything for the pain. So other reasons why they may need more of it, other than just that they're in a ton of pain, could be because if they're chronically using any like CNS depressants, they may require more than usual in order to kind of get the same sedative effects. Because if their baseline, if you think about someone who's like, kind of baseline sedative actions here because they don't use any substances, and all of a sudden you have someone who's like a chronic alcohol abuser, they may be up here in terms of their normal sedation action because they're chronically drinking. So it takes a lot more drug in order to overcome that to see the sedation you're looking for. So it just depends on how used they are to CNS depressants. Just like we saw those patients have an increased MAC as well, if they're alcohol abusers and things like that. So yeah, it could be just pharmacogenetic resistance to the drug. That could be another thing too that is hard to account for. Isabel saying the ophthalmologist I work for use Versed in all his cataract surgeries. Yeah. So, and again, if you're using, and I think about it in terms of like invasiveness, it's probably a little less invasive than something like, general surgery. Maybe that's all you need is Versed. I recently had a family member who had a vasectomy, and they got a dose of oral diazepam before going to the office. So that way he's kind of a little inebriated going in, and then you got a little bit of local anesthetic, which we'll talk about later, some lidocaine. That's all I needed, right? So again, very dependent on the practice, what they require in terms of like pain relief, in terms of what they require in terms of anxiolysis and amnestic properties. So again, it's very practice dependent there from that standpoint. I'm trying to give you kind of the broad sort of like general idea of how we're using this stuff here, and kind of more speaking to from my experience, because that's what I've experienced. And so if you have, other experiences too, let me know, because I love talking about that stuff and comparing and contrasting some of that. Okay, so other things that we can use here are going to be our opioid analgesics, and this is pretty frequently done, especially if it's something painful like, a displaced fracture or something. And so we can utilize some of our, potent opioids. You'll see a lot of fentanyl and fentanyl adjacent drugs like Remi, Sue, and alfentanil being used here. They do help out with things like awareness during anesthesia, kind of that locked-in sort of phenomenon we talk about where the patient may be conscious during, when they're like paralyzed or something like that. We definitely don't want that to happen. So opioids can help out with this and kind of decrease the post-op recall. One thing you want to be really careful with fentanyl specifically, this is a unique thing to fentanyl, is if you give really big doses too quickly, you can actually cause chest wall rigidity, which can impair ventilation, right? So if all your intercostal muscles seize up and they can't really move, you're not going to move a ton of air anymore. And so in those cases there, you can actually cause death of the patient unless you can reverse it. Actually, we use Narcan to reverse that, although consider the fact they may be back in pain again. So again, it's kind of a double-edged sword from that standpoint. We do see that the less opioids you can use during surgery, typically the better your outcomes are. If you're having to use a lot, especially in the post-operative period, you do see more prolonged ventilatory support, which puts you at risk for things like infections, GI complications like ileus, constipation, bladder issues. So for the most part, if you can try to get away from as many opioids as possible during surgery and after surgery, that's generally a good thing, right? And so for instance, we can try to do things like more specific administration of them. So instead of giving systemic opioids, maybe something like an epidural might be a good option there, right? And so that can be useful for things like, C-sections and during labor, which we talked about previously there. So it just really depends, on the setting, and again, what the providers are most comfortable with and the anesthesiologists are used to doing there. And again, we use a lot of opioids in the post-operative anesthesia section, right? So just like we were talking about, I think, is that one of your prescription assignments? I don't remember if it's this one or the previous one. Open that up real quick. Yeah, so actually is pertaining right to your assignment for this time around, which I think is probably what due next week, I think. But yeah, looking at that, you can see that you'll use a lot of post-operative opioids in order to help out with more moderate to severe pain the patient may be experiencing there. So very, very handy. But again, the less you have to use overall, the better. So good drugs, but good in limited amounts. As I mentioned, fentanyl and sufentanil tend to be like very potent drugs. Again, you're dosing in micrograms of fentanyl as opposed to like milligrams of morphine or something like that. And again, they're useful as adjuncts, so good for providing sort of perioperative analgesia, helping your inhaled anesthetics to work a little bit better. Remy and Al, I typically see these used just in surgery. I think fentanyl is really the only thing I've seen used outside of the OR. Sometimes I'll see some sufentanil being used in the cardiac ICU, but again, that's just my experience. But certainly any of them will work pretty similar to one another. As I mentioned, Remy and alfentanil typically is like co-induction agent. So if you're giving inhaled anesthetics along with IV drugs at the same time, it helps to reduce that consciousness much more quickly. So that way you can knock the patient down quick, do your surgery, and then have them recover and then move on out, right? So other drugs we can see being used here include morphine. Certainly we use plenty of that in the post-operative setting. Fentanyl, all the fentanyl congeners we can mention there. Again, most of these are fairly, all of the fentanyl family is typically fairly rapid acting, usually pretty short acting for the most part, with Remy probably being the most short acting one of the bunch. So up next, again, we talked about opioids before, so you remember Narcan, how that's our main reversal agent. Remember the respiratory CNS depressant effects of opioids, that kind of stuff. I'm not going to reiterate because we talked about that before, so you should remember some of that. Another new drug that we have here is propofol. I'm sure most of you have, heard of its notoriety as the drug that killed Michael Jackson. And basically he was using it for sleep. And again, using propofol for sleep is like trying to use a bazooka to kill an anthill or something like that. So pretty wild stuff that he was using this for sleep purposes. But again, I guess it worked. Probably too well though, as we see there. So a very unfortunate accident that happened with him. But that's where a lot of people know propofol from, I think, at least in the recent couple of years here. Some people call this the milk of amnesia. I don't know if I have a picture of it or not, but if you ever see propofol, it is a very white, milky sort of substance. It looks just like milk if you see it. Let me show you a picture. I've not gotten a chance to see it. So if you look here, you can see, and it's hard to see against a white background. Maybe it's a better picture there. So you can see how it just looks like a bottle of milk or something. That's because it has to go into a lipid emulsion and for solubility purposes there. So what's actually interesting is because it goes into this lipid emulsion, you can actually get calories from that. So sometimes if patients are getting like a lot of IV propofol, we'll factor in how many grams of fat they get from that into their caloric intake, which is kind of cool. Not done too often. Usually it's not of all that clinical import there, but anyway, so propofol is actually it's a really good drug. It's like really good, especially for like adult patients who need like ambulatory surgery, if they're in the ER for like a procedural sort of sedation. It's a really good drug for that because it has pretty quick onset and then pretty fast offset. In the ICU setting, you'll see this used as a lot for patients for sedation while they're on the ventilator. The nice thing here is that it does provide both analgesia and sedation. So, for instance, with some patients who are intubated, they may require the combo of a benzo like Versed plus something like fentanyl in order to get the analgesia and sedation. Some patients just require propofol by itself because you get the kind of the combo in there. Now we use that when doing tube feeding formulas, 1 kcal per ml. Oh, interesting. I haven't done the math for that in a while, so that's good to know there. Yeah, so you can figure out how many like mLs are getting, in a day for sedation or something, and yeah, you can figure out how much calories are going in that. I always love my dietitians and nutritionists in class. That was probably cool little anecdotes like that. Anyway, so again, good for induction. I see this a lot for like things like with adult patients. If you need like a shoulder reduction or something, or some kind of joint reduction, this is an awesome drug for that. The patient will become a little loopy for a bit. They're nice and relaxed and kind of loosey goosey. You pop the shoulder back in a joint, and then you let them recover, and they're good to go. So it's very, very nice from that standpoint. This is another GABA A receptor agonist, so kind of directly increasing chloride influx into these neurons. Again, actions are very similar to all of these. They may have slightly different targets, but ultimately they're all helping GABA to work that much better, right? So again, good for the operating room, good for procedural sedations, which I'll talk more specifically about. I've kind of alluded to it a lot already. And then again, we're going to see a lot of this being used in ICU patients for more prolonged sedation. Okay. Some of the things you want to be watchful for, though, is that one, you can't see hypertriglyceridemia from this. Probably not by itself, but you could certainly see this in patients who may be getting this along with like total parenteral nutrition, where they're getting IV fat emulsion anyway for their kind of fat requirements. You may be able to see that there, but certainly something you could watch for. And then there's another condition you can have with like your ICU patients who are getting this for like prolonged continuous sedation, and that's something called PRIS, which is kind of a cute name for something that's like kind of awful. And they get this propofol-related infusion syndrome, where they can develop this like really severe acidosis that comes about from having a high dose for long-term use there. And so I always, like to caution people from using, it's good as a sedative, but even if you're having to kind of use really high doses for a long period of time, you may want to consider kind of giving them a break after a while to prevent that PRIS from happening there. So in terms of the kinetics here, we like it because it has a really short half-life. It's able to kind of get into its job and then get back out really quickly. So useful as either continuous infusion that you can titrate, useful for quick procedures. That way you only need like one dose in a lot of cases there. Interestingly enough, and again, I always like to point out where things can change the color of your urine or your feces, this can actually turn your urine green. Pretty wild, right? And so again, I don't know the reason why that happens, what the byproduct is, but it comes out kind of green. And you may look at urine like that and be like, wow, that looks infected. It's just the propofol that they're on. So if you see a nice white infusion going into the patient and green urine coming out, that's probably what it is. Not everyone, but some people will develop this. In terms of other adverse effects, this is something where hypotension is fairly common with this, especially if you're requiring a lot to sedate your patient. And certainly you're going to see some respiratory depression, not often a problem with just like a single dose for like a procedural sedation, but if you're using it for more long-term or repeated doses, definitely you can see that. The hypotension point, very good point. Is good for St. Patrick's Day. I would not recommend using any propofol during St. Patrick's Day, especially if you're doing any drinking along with that, because you might meet a very bad fate if that was the case. But definitely watch for the hypotension with this one. I see this a lot in the ICU setting, and I see this like with residents and stuff, where I'd be, and again, I always like to tell this story because it makes me sound really smart, but I was in the ICU one time on rounds, and we had this patient who was coming in for sepsis, and they were on like 3 different vasopressors. I think they're on norepinephrine, dopamine, and I think they're on like a vasopressin drip. And just really having a hard time keeping their blood pressure under control. And so I was looking at their med list, and I saw for sedation, they're on propofol. And I said, well, hey, actually propofol can cause hypotension. What if we switch them over to like Versed and fentanyl and then see what happens to the blood pressure? Sure enough, patient ended up coming off like 2 of the vasopressors, right? So again, sometimes by switching out your medications to something that's more favorable based off the fact that, hey, this patient is hypotensive because of sepsis, let's not add on something else that causes them to be hypotensive. If it's like a trauma patient whose blood pressure is okay, then yeah, this probably is a really good drug for them. So really just depends on the clinical situation there. So I think we all agree ew to the green urine, but again, I always like to point out kind of unique stuff like that. I always think it's interesting. So someone said, does propofol cause amnesia? I think, yes, to put it lightly, it does cause amnesia. Oftentimes, I think those videos you see a lot of times of like people recovering from anesthesia where like they forget who their husbands are, or they forget forget weird details and they're kind of acting silly. A lot of times that is the effects of things like propofol. They call it milk of amnesia as a sort of a kind of a colloquial term for it. So certainly you'll see a lot of amnestic properties seen with propofol, just like you would with the benzo, just like you would with a lot of these drugs here. So yes. You do propofol, you will forget quite a few things. But next up, we have etomidate. This is something I see used much more reserved for rapid sequence intubations, or RSI. We will talk about that specifically when we get into the emergency medicine section coming up in the final section of this course here. Isn't that weird to think we're almost to the final section of this course? It's gone by so quick. Probably not to y'all because you had to listen to me for this many hours, but etomidate is really good because it is helpful. It does not really cause any cardiovascular changes. So whereas it was something like, a barbiturate or a propofol can drop the blood pressure, this really doesn't do that. So it doesn't really hit the cardiovascular system. It doesn't hit the respiratory drive as hard as something like a propofol would, and they have really rapid loss of consciousness. And so that's good because that helps us to be able to knock the patient out so we can intubate them very quickly and then allow the drug to wear off. So that way, if we need to do another neuro exam or switch them over to something else for the ICU, whatever the case may be, This is why we like etomidate. I've seen it used occasionally for some procedural sedation, but for the most part, in the ER setting, rapid sequence intubation is probably the most common use I see for it. Maybe Jackson knows from being on the rigs or something. He's probably used it quite a bit as well. Here you're going to see that we will oftentimes give this with opioid analgesics in order to help out with pain associated with things like intubation on occasion there. It also helps out kind of decreasing some spontaneous muscle movements and things like that. But the real benefit is they recover within like 10 minutes. So if I had a patient who's like seizing and they need to be intubated and I need to know if they're still seizing or not after the drugs wear off, this is a drug to use because it does have that short duration of action and you'll be able to tell if your patient is still actually having convulsive seizures there. You can see here, really rapid half-life for the most part. In terms of adverse effects, though, some things you can see includes myoclonic activity, which is not great. You may see your patient kind of seize up a little bit. It's not like malignant hyperthermia type of rigidity, but you may see things like trismus that can happen in the jaw, so that may make it more difficult in order to intubate the patients. That can be a challenge there, but again, that's why you're using paralytics too for those patients. Jackson said, yes, it was our protocol for RSI, etomidate, Ativan, then sucks if needed. Yeah. We'll talk about succinylcholine, I think, in the ER section coming up next time. But yeah, etomidate, Ativan sounds like a pretty decent combo there to get the patient ready for intubation. But here you're going to see, again, some postoperative nausea, vomiting. Now, if they're intubated and the cuff's inflated, you're protecting their airway, so vomiting's not as big of an issue, but certainly things like Zofran can help to prevent this. And interestingly enough, this drug uniquely can cause adrenocortical suppression. So this is really important to tell, if you do this down the ICU, in the ER, get your patient intubated with etomidate and then send them up to the ICU. You want to let the ICU people know, because one of the things you may have trouble with when they have this adrenocortical suppression is they have a hard time controlling their blood pressure. And you'll see this too, like in septic patients where they're not releasing enough cortisol, and that makes it more difficult to control blood pressure because they're losing that sort of mineralocorticoid effect. And so you may have to give them supplemental hydrocortisone in order to help cover for that. So that's something you may see uniquely with etomidate, you don't really see with much else. And then we have ketamine. Ketamine, again, is one of my favorite drugs, I think, just from its use as like a veterinary anesthetic. So the same thing we use to knock out horses, we can use for our children who need reduction of their joints. It's also seeing a lot of use for things like depression, PTSD. So I think, the kind of the sky's the limit in terms of ketamine with its uses, which is pretty cool. So I think we're going to see a lot more new stuff as time goes on. The reason why this is different is because this actually doesn't work through GABA at all. This is actually working to block the NMDA receptor, which is a glutamate receptor. So by blocking glutamate, you're able to get what they call a dissociative anesthetic effect, or dissociative anesthesia. And so what's really interesting with this is that it causes basically, I almost think of it as like kind of disconnecting the brain from all external stimuli. And so, for instance, you can have someone who, for all intents and purposes, appears to be awake, maybe kind of like, saying certain words may not make a lot of sense. And you could be like reducing their fracture and they have no cognizance of what's going on. And some people even talk about it as sort of like a mind out of body experience that they can see there, which kind of makes sense because it's kind of chemically related to phencyclidine or PCP, which is, if anyone's familiar with that, another name for its angel dust. People have become, pretty aggressive and pretty wild while on PCP. You don't really see the same thing with ketamine though. But provides analgesia, provides amnesia. The patient is basically, they're still going to be breathing for the most part. It doesn't really cause a lot of respiratory depression, which is another really good thing. That's why we like it for kids, is because we can give it, if a kid needs a fracture reduction, we can give this to them and not really worry about their respiratory drive. We still have like a respiratory therapist up there that is able to monitor, but we oftentimes don't need to breathe for them, and with less risk than something like propofol or a benzo or things like that. So that's why we like it from the kid perspective. So really good and oftentimes we tell them before they go under, we'll say like, usually they've already got like a dose of a benzo, maybe some fentanyl, if it's like a fracture. So they're already kind of feeling pretty good anyway. And we'll say like, what's your favorite thing to do? And they're like, oh, I love playing baseball. They're like, well, who's your favorite baseball player? And they'll say, Mickey Mantle. I don't know baseball players, but they'll say some baseball player, and they'll be like, just imagine you're playing baseball with them. Or my favorites are like the kids that came to go to Disney and they end up like falling out or something and breaking an arm. And so we're like, just imagine you're going on Space Mountain with Mickey Mouse and just have a good dream. And so we'll put them down and they'll come back and they're like, I had the best dream. I was hanging out with Mickey Mouse and Mickey Mantle. We were playing baseball and it was fantastic. And the kids had a great time. We'll see that's not always the case, especially with adult patients. But that's kind of the experience I have with giving it to children. So nice, really nice from that standpoint. Pretty good stuff. So, and again, this is really the only IV anesthetic that has both those anesthetic and analgesic properties, which is really good. Some people are concerned if a patient has an increased intracranial pressure that this can actually worsen that. So you'll probably not see this used for a lot of things like, head traumas and things like that. But other than that, it's a really good drug from that standpoint. The other cases we can use it for things like status asthmaticus because it actually helps to release catecholamine, so you can actually cause some bronchodilation. But on that same axis there, you can also see that increases in blood pressure and heart rate can occur. So if they're already like really hypertensive, this probably isn't the best drug for them, but maybe they're hypotensive because of, say for instance, they're septic or something and need to be intubated. This can be a good drug for that from that standpoint. And again, it doesn't really hit the respiratory drive as hard as you would see with other drugs. And for the most part, they'll stay breathing there, no problem. The one thing I do want to be cautious with is they do happen to have a decent amount of post-op nausea, vomiting. So you probably want to pre-medicate with that, which you're likely to do with most of these drugs anyway. And they also have this high incidence of post-op psychic phenomenon, which not like your patient can like read your mind all of a sudden, which would be pretty cool. But they can have what they call a dysphoric reaction that can occur. This is more often seen with adult patients, and I feel like kind of like the more like psychological baggage they have going into a ketamine experience, the more likely are they come out having a bad experience. And so you may find patients become very like anxious or aggressive, even violent in some cases as they're coming out of this ketamine that they've gotten for whatever procedure that they had. So again, it can be one of those things where you may need to medicate them with things like benzos after the fact in order to help calm them down. Again, I see this more with adult patients. With kids, oftentimes they just have really good dreams and they think they have a great time while they're getting that fracture reduced. With adult patients, that's where I see more so like propofol being used for those like short-term sort of procedural sedations there, right? So if I had like an adult patient who had like, I don't know, pneumothorax, you need to place a chest tube, a little bit of propofol is going to be really good for that patient. If it's a kid who had their leg broken and sticking out of their, it's displaced, it's open fracture, ketamine is a really good drug for that case. I mean, probably surgery is good for that kid, but if it's something that you can do in the ER, ketamine is a drug we go with. Anyway, I can see I'm kind of rambling on about this stuff because I find it so interesting. But looking here, you can get a good comparison between the various drugs that we've talked about here. So again, I may ask you something like, okay, what drug would be better for a patient who's hypotensive? Well, propofol probably wouldn't be a good option there. Maybe something like ketamine would be good. Or I say something like a patient has increased intracranial pressure. What would be a good option for that patient? Well, then ketamine might be contraindicated from that standpoint. So little things like that, little differences I'd like you to be able to kind of key in on in terms of like testing about which drugs may be most appropriate or least appropriate. Those kind of things are questions I'll be asking on the exam, for instance. So there's just, let me see how much I have. Yeah, let me finish up this section. I'll finish with this, and then we'll save the rest for our next meeting. So anyway, this idea of conscious sedation, this is basically, again, kind of talking about the different levels of sedation here. So conscious sedation or like procedural sedation is basically like kind of drug-induced alleviation of anxiety and pain. So this is what we do when we don't really need the patient to be completely unconscious. It's okay if they're still awake. They can kind of be talking to us a little bit. Maybe they're a little loopy. But the main thing is they're maintaining a patent airway. They remain responsive to verbal commands, and you can do things to them like, if they need like an incision and drainage, if they need something like a dialysis catheter placed, if they need, more minor stuff that's not super invasive, conscious sedation is totally appropriate here. And you're typically going to be seeing things like benzos being used, propofol, ketamine, maybe even like fentanyl occasionally. Those are probably the most common ones. The benefits of using like a benzo or an opioid is that they're really easily reversed. So for benzos, I can use flumazenil. For opioids, I can use Narcan or naloxone. For propofol or ketamine, they're usually short acting, so I don't really have to worry about reversing them. But if something did go wrong, I just have to give it time. I can't really do anything about it. If they're having a bad reaction, they're just going to have to deal with it until the drug is out of the system, basically. Which fortunately is a short period of time. That's one of the downsides to that. Occasionally may need to do something like conscious sedation in different settings. So some settings you might not think about. So one may be something like in the ICU, for instance. And so we'll talk about a specific drug I use a lot there. This is occasionally required like in an ICU critical care sort of setting here. You may see this in patients who, under like, a lot of severe physiologic stress. You may see this in patients who require mechanical ventilation for prolonged periods of time. So as I mentioned, like for for certain patients may require things like fentanyl, Versed, drips in order to help keep them, synchronized with the ventilator. Oftentimes we may either require that combination of a sedative, hypnotic plus an opioid. Sometimes we may need things like neuromuscular blockers, which are NMBs, which are basically paralytic drugs. I'll talk a lot about that in the emergency medicine section. That'll come up then. And then here's another drug here called dexmedetomidine or Precedex, which is a relatively new drug, but it's seeing a lot of good use in both the surgical realm and the ICU realm. I'm seeing a ton more use of this nowadays than I was when I was even in school. And it was relatively new back then. So nowadays it has like a generic availability, and so I'm seeing a lot more use of it. But this is called dexmedetomidine or Precedex. It is a alpha-2 agonist. So if you know what clonidine does, this does the same thing basically. However, this is going to be an IV analgesic sort of sedative sort of drug here. Now, when I say analgesic, it's pretty minor. Like it's not going to replace something like an opioid, and it's probably not going to be as heavy of a sedative as something like a benzo. But if I just need someone kind of lightly chilled out, I need them to not be moving around a bunch because maybe they just had surgery, or maybe for whatever reason, maybe need to do a light procedure. Precedex tend to be pretty good here. You can see, just like you would with clonidine, hypotension, bradycardia are certainly possible. So from a cardiovascular standpoint, that's the thing I'll be looking for. Most of the time, you can either give them like little spritzers if you need to, like if they need like just a little minor dose for like a minor procedure, like maybe you're placing an art line or something. For more prolonged cases though, and I see this a lot like in the ICU, you'll do like a bolus followed by a continuous infusion. Because there's a short half-life, you can kind of titrate it pretty easily from that standpoint. So I see a lot of that used in the ICU setting. I'm starting to see more of it used in the OR nowadays. But another drug here, or talking about another situation, so for deep sedation, so this is for something to where the patient is not going to be easily aroused. Maybe they'll respond to some painful stimuli like a sternal rub, but this is going to be where they are oftentimes unable to maintain a patent airway, probably not going to respond to a lot of stimuli, and so may be really indistinguishable from having like full-on anesthesia like you see for surgery. And so oftentimes this is where you get into things like barbiturates, propofol, opioids, ketamine, heavy-duty benzos, like heavy doses of benzos. And so again, this is all on a scale, right? So again, going from procedural sedation, light sedation, down to deep sedation, there's a lot of stuff in between there to consider. So how you choose your anesthetic is going to be dependent on things like the type of surgery you're doing. So again, depending on how invasive it is or how long the surgery is going to be taking there, do you need repeat doses available if it's going to take a while? I remember one time, I'd never really known like what a spica cast was before, and I realized it was like the whole like bottom half of this like little kid that had, I can't remember which specific fracture they had, but like we had to like basically cast up the entire lower half of the patient, and it was something that we, took an hour plus, and so we needed repeated doses of the drug in order to keep them sedate enough for the orthopedic surgeon to be able to do what they needed to do, right? You may be dependent on the condition, the age of the patient, sometimes previous experiences with anesthesia. So if you know they have a bad reaction to ketamine, don't give them more ketamine, right? You just know they're going to be primed for another dysphoric reaction. Be aware of like your available equipment, right? So do you have the ability to intubate that patient if things go wrong? Most places will, right? That's going to be one of the requirements. So you have the ability to do that, but do you have personnel to do this, right? And so frequently it's either at the preference of the provider, the anesthesiologist, the patient. Oftentimes in the ER setting, whoever's doing the procedure, whether it's like the orthopedist or whoever else is coming down, they may be the one doing the procedure, and then like the ER doc is going to be the sedationist, right? They're the ones kind of providing that. Whereas in other cases, maybe anesthesiology is doing that. Just depends on the situation there, right? I think I'm just speaking from my perspective, kind of what I've seen in my days. Although how long they are, though, I've seen some stuff, but not everything. And so in terms of like adjunct agents, again, remember benzos are good for controlling anxiety. Good as an anxiolytic, good to facilitate amnesia. Barbiturates are really good for sedation. Occasionally, we're going to do things like antihistamines, like Benadryl. This may be useful if they have any kind of like allergic reactions or anything. And honestly, I should take off ranitidine. I should put famotidine because that is off the market. I can't believe I have an oversight like that. Sometimes this can help if patients have like kind of increased gastric acidity, if they have like any kind of like reflux, because again, a lot of times those like kind of smooth muscle bits are going to be a little bit relaxed, so you can see reflux. That can be useful there, although I don't see it that often. But definitely a lot of ondansetron as an antiemetic. You can see Reglan, any of those antiemetics will work. Opioids, certainly for analgesic purposes. I see a lot of fentanyl, morphine, sometimes Dilaudid. And then anticholinergics are good for amnesia as well. So a lot of times, like prior to surgery, I'll see a lot of, or especially, and specifically, this is going to be like our orthopedic surgeons prior to having like a really long spinal fusion procedure that it takes like all day long, basically. They will oftentimes do transderm scope, just like you would for like a cruise or something to prevent motion sickness. They'll use that behind the ear to help with some anesthetic properties because anticholinergics can be useful for that along with benzos. They can also be good because they help out with like bradycardia, and also if they have like a lot of secretions, the anticholinergic will dry them out to some degree, which is good, and it kind of helps facilitate good oxygenation from that standpoint. So that's it for that. So kind of think about, which situations might, a certain type of sedative or analgesic be good for one setting versus another. Think about contraindications, think about side effects. Those are kind of things I want you to kind of key in on in terms of test questions I might be asking. But beyond that, I think I'm going to be cutting off for today. So I hope you all enjoy this extra few minutes you have. Hopefully you enjoy the rest of your week. Hopefully you're studying for all of it. Those are heavy air quotes. You're studying for all of that. Otherwise, I will see you next time we meet, which I believe is going to be, we meet again on next Tuesday. So yeah, so thanks for joining me. You guys are my stalwart crew, all 14 to 15 of you. I appreciate you for being here. It's not the same as 40 people, but they can catch up later, no big deal. If you have questions in the meantime, either email me, post them up on the sticky board or chat, and I'll get to them. Not the chat, but on the sticky board, and I'll get to them next time. And you guys have a great rest of your week and weekend. Y'all take it easy as well.